And good morning, everyone. Welcome to Internal Medicine Grand Rounds. For today, we are pleased this morning to have the 2024 Lung TYAM Lecture, which is typically hosted by Oncology and Hematology. And I'm going to introduce to you Dr. Higazi, who will introduce our speaker, Dr. Malki, who will be speaking about optimizing outcomes for patients with mismatched unrelated donor hematopoietic cell transplant. But before doing that, I'd like to talk a little bit about Dr. Yam. He was an internationally known hem-onc specialist who passed away in May of 2013. He was 77 years old. He was a prolific, widely published researcher and authority on blood diseases and diagnostic biomarkers. His research and seminal studies has helped to establish a test for hairy cell leukemia and other blood disorders and cancers. He published over 190 manuscripts. Many of those have become classics. Although he had many medical achievements throughout his career, he is most fondly remembered for not only guiding medical students and assistants to become successful in medicine and academia, as well as science, but he was also known for his gentle, confident way that he had with patients and their families. Dr. Yam was born in China in 1936, received his medical degree from the National Taiwan University in 1961, and served his internship at Cook County Hospital. He did his residency at Mount Sinai Medical Center in Chicago and fellowship training in New England Medical Center in Boston with Bill Crosby, a giant in American hematology. After working for Scripps Clinic and Research Foundation in La Jolla, Dr. Yam moved to the University of Louisville in 1974, and he retired as a professor of medicine from the university and as chief of hematology at the Rex Robley VA Medical Center in Louisville. He will always be fondly remembered by his colleagues, trainees, and patients. Introducing our YAM speaker would be our section chief in blood cancers appropriately and cellular therapeutics and transplantation, Dr. Mohammed Higazi, who is up for associate professor starting in the next academic year. And take it away, Dr. Higazi.
Thank you. Thank you, Dr. Williams. If I may, just in a few seconds, I was a student, maybe one of the very last few students who rotated with Dr. Yam almost 15 years ago to the date now, where I rounded with him and saw patients in the VA where he was practicing in the very last few months. And I do remember having a nice letter written by him and a lot of words of wisdom from him guiding me to join this field. Today, I'm going to introduce our Grand Round speaker, Dr. Monzr Al-Malki. Dr. Al-Malki is an associate professor in the Division of Leukemia, Department of Hematology, Oncology, and Hematopoietic Stem Cell Transplant at City of Hope, one of the biggest, if not the biggest, transplant center here in the United States. He is the director of the Unrelated Donor Bone Marrow Transplant program at City of Hope. He's also the director of the Haploidentical Transplant program. He's a physician scientist whose research is focused on the use of mismatched related and unrelated donors as sources for stem cell transplantation. He treats patients with blood cancers who otherwise don't have matched donors available. His research is focused mainly on improving access to transplantation in older patients, minorities, and patients with refractory blood cancers. He has ongoing studies to improve safety of mismatched graft by either in vivo or ex vivo T-cell depletion. Needless to say, he was the first author on one of the pivotal studies for mismatched unrelated donors that maybe he will shed some light on. That was published at the end of 2022 in Blood, the biggest journal that we have in hematology in the world. And without further ado, thank you very much, Dr. Al-Malki, for joining us this early from California. And I know it's 5 o'clock there. Thank you for joining.
Thank you. Good morning, everyone. Would like to start by thanking all of you being here this morning, and thanks, Dr. Higazi, for the kind invite. Wanted to be with you, didn't work out due to service, so thank you for having me. Those are my disclosures for this morning, for this talk. And our objectives for this talk will be to shed some light on the importance of alternative donor transplant in the current era. We'll talk about the historical outcome of mismatch unrelated donor, and we'll discuss optimizing the choice of the donor using the conventional GvHD platform. And then later, we'll discuss some of the options we have to optimize outcome with the novel platforms and some of the future directions. So as you are all aware of, allogeneic transplant is a proven curative therapy for many hematological malignancies. Transplant from HLA matched sibling donor is still the golden standard. Both major and minor histocompatibility are matched. So risk of GvHD is the less than other options we have, and outcome supposed to be the best. Chances for matched sibling donor is in the range of 20 to 30%, and the rest of the patient will have to really rely on alternative donors. This slide shows the increase in number of transplant in the United States over time, and mostly due to improve in donor availability with an MDP effort to recruit more donors and availability and advanced, in that has been achieved in the last decades in alternative donor transplant, in advances in supportive care, and in improvement in our conditioning and GvHD prophylaxis, all helped to improve the access to transplant. As we can see here, two donors type, including MUD and Haplo, are increasing significantly, and both are exceeding the number of matched sibling donor transplants done in the United States. In this graph here, we can see the likelihood of finding 8 out of 8 match unrelated donor among all different ethnic groups. And as we can appreciate here, patients of minority ancestry have low chances of finding a match unrelated donor. Some like African American and Hispanic are in the range of 20 to 30%. This is not only due to underrepresentation of those ethnic groups in the donor pool, but also due to increase in genetic variation in HLA in those groups. And also, when this paper shows that after typing and workup and medical clearance and all the issues we go through to get the donor lined up for a transplant, overall availability to proceed with donation dropped significantly. For example, here down from 75% in white to 51%, and other ethnic group can go to 30 to 40%, as well as shown in this table. All those who are otherwise eligible for transplant and will need to go to this curative procedure will rely on alternative donor transplant. And with the recent advances in mismatch unrelated donor, haplocohort becoming very important donor source, optimization of the outcome of those donors will become unmet need for us. And for the sake of this talk, I'm going to mention, focus on mismatch unrelated donor. So just starting by historical, this is one of the first paper confirming the importance of high resolution HLA typing in predicting outcome of mismatch unrelated donor transplant. And in this study, it was close to 2,000 patients transplanted in between 88 and 96, mostly AML, ALL, and CML, mostly gut and bone marrow grafts and myeloablative regimen, which was the most common procedure used at that time, and then a long follow-up with the 9 years. And as we can see here in the Kaplan-Meier curves, we are reflecting, it shows increase in risk of GvHD, as you can see on the left side, associated with mismatched donor. And, we can see how that, reflecting on the survival on the right side. And in this note also that there is a cumulative increase in risk with the higher number of mismatches we use. So this paper was later published in 2007, long time ago now, larger sample of patients, 4,000, also around the same time frame, 88 to 2003, and focus on similar population with bone marrow graft and myeloablative conditioning. Again, long follow-up, and then the results are similar here. we can see every mismatch we are choosing, survival is around 10% lower. This was independent of disease risk, as you can see. And only exception to this was in advanced stage disease, where the difference between 7 out of 8 and 8 out of 8 is very small. In this study, they analyzed outcome based on antigen versus allele also. And it shows here that either one is bad. And they compare allele to antigen here, and there was no difference in survival, NRM or GvHD. So allele is as bad as antigen, and I hear that from a lot. I would like information with this allele mismatch rather than antigen mismatch, but really, if you look at this large sample here, the difference is not there. So mismatch is bad regardless of the depth of HLA testing. And this to confirm prior finding in some of the homogeneous type of treated leukemia and MDS population, again, myeloablative bone marrow graft with calcineurin-based GvHD prophylaxis, which was the historical standard of care. And as you can see across all lines here, A, B, C, D, R mismatch are equally deleterious, and no difference when compared to antigen and allele again. So again, all locus are equally bad, and antigen and allele are equally bad. In this population, the effect of DQ was evaluated, and despite the possibility of increase in GvHD reported in other paper, DQ mismatch in this large analysis did not affect survival. And that's where we think 8 out of 8 are a prerequisite for a successful transplant, while 9 out of the 10, which is a mismatched DQ, should not affect outcome. Just to highlight here that when DQ mismatch was a second mismatch, like when it was added to 7 out of 8, DQ did not even affect survival. So same, DQ increased GvHD, but does not affect survival. In 2014, in this paper published by Joe Badala from Moffitt, again, evaluated 8,000 now patients with, and he included some pediatric. But this is the first paper that include reduced intensity conditioning and start to show peripheral blood stem cell, which started to emerge at that time. A similar type of population, mostly calcineurin inhibitor-based GvHD prophylaxis. And here we are we're showing similar outcome, as you see across the table lines with increased number of mismatch. There is no effect on relapse. So mismatching does not improve your outcome due to decrease in relapse, as it was thought. And on multivariable analysis with proper adjustment, different kind of GvHD antigen prophylaxis additions like methotrexate, mini-methotrexate, ATG, MMF, all did not affect any outcome in this. So here, even with advanced stage, as we showed earlier with myeloablative, did not really benefit mismatch. So when we use reduced intensity, the control over the cancer is lower, and mismatching makes more problems. So, both again showing similar type of finding, allele and antigen are equally bad, and there's no association with relapse. Especially, actually, this is something we used to hear, mismatching HLA-C could cause improvement in relapse risk, but this paper did not take in consideration KIR variation, but mismatching C obviously did not help either. So this study also confirmed that among 8 out of 8 and 7 out of 8, DQ and now DP now starting to show up did not really affect outcome. It did increase GvHD, but survival was the same. So again, 8 out of 8 is prerequisite. And again, I apologize for putting a lot of tables here, but I'm giving you a summary for that. And this is the most recent publication we have. It's published in 2020, and it has a huge number of patients, 34,000 patients with multiple, different malignant heme disease, transplanted all the way from 88 to 2016. So there is overlap with other studies. 2/3 of this population had myeloablative regimen, and 50% had bone marrow versus BBSC graft. So kind of reflecting of what we do currently, as they were inclusive of those cases recent years, and similar to the older studies and showing similar type of confirmatory of the signal, additive adverse effects with higher number of mismatch, as we can see with here the hazard ratio increasing with higher number of mismatch. It also confirmed that all locus-specific mismatch impact outcome, and DR mismatch was a little bit less significance due to sample number. But again, ABCDR are prerequisite, and mismatching those did not show any improvement in relapse. What about disease now? Is different disease showing different type of things? This is a hallmark study, 2,000 patients with AML undergoing transplant, and you know, in the 2002 to 2006 time frame, 50% myeloablative, 70% BBSC, similar type of message, higher NRM with increase, with no increase in impact on relapse, leading to lower survival in patients with mismatch unrelated donor transplant. Looking at patient with AML now with unfavorable cytogenetics, it's in CR1. So CR1 unfavorable risk. Do we impact those? Do we have any improvement in their outcome? And that shows the same type of message, and the answer no. And in MDS, again, it's different type of kinetic, different type of disease, slower disease. What do we see? 700 patients here reported to see IBMTR from 2002 to 2006, so around the same time. The difference in outcome was significant when mismatch unrelated donor was used, again with the same increase in non-relapse mortality and no impact on relapse. So different diseases, different kinetics is not showing any difference also on the outcome of those patients who needed a mismatch unrelated donor, or who had only mismatch. We went ahead and did the study in my center, and we had a different type of platform. We thought maybe a conventional GvHD prophylaxis, like the tacrolimus and sirolimus that we use, might have some impact on mismatch unrelated donor. In this platform, there was multiple different studies going through the years. One study we added methotrexate or MMF, and one study we added ATG for those cases, trying to improve outcome of those mismatch unrelated donor. And we went back, we had 500 patients in this, all very homogeneous GvHD platform with tacro-siro. And patients, in this population, around more than half of the patients received reduced intensity conditioning. All 100% received BBSC. So very, very nice study with the stable, homogeneous type of population. But most of the patients in the study received the third agent, either methotrexate or ATG, really. And again, even with this platform, we were not able to improve the incidence of, we were able to improve the incidence of acute graft versus host disease. So we didn't have increase in AGVHD. We thought this will be a nice signal for this type of platform, but the impact on survival remained the same. We had 10% decrease in survival on 7 out of 8 when we compare to 8 out of 8, as you can see in these curves. And mostly, really, we start to see now more, effect on chronic graft versus host disease and mortality related to infection at that time. So again, with the different tacrolimus, sirolimus platform, we did not see improvement. This also was, we were comparing the based on the third agent that was added, methotrexate or ATG. Again, the same, message, smaller number though. And here we show that all mismatches in those, 4 loci did not show, any improvement. And there was a lower number of DRP. That's why it was not significant here. But we don't use DR, mismatch often, or we didn't use in the past DR mismatch often. So that's probably why. But really looking at that, the effect was similar across all So to summarize this section, I would say that mismatch unrelated donor outcome is worse than MUD. The outcome is worse with higher number of mismatch loci. Allele mismatch is as bad as antigen mismatch, and all 8 loci mismatches are the same. This is all stand correct in the setting of any conditioning regimen. I showed myeloablative and reduced intensity. The message was similar, and this stands correct only in the setting of conventional GvHD prophylaxis. When I say conventional GvHD prophylaxis, meaning the calcineurin based either with methotrexate or MMF. This stands correct regardless of disease or even the stage of the disease. And, donor age, gender, ABO, CMV, pregnancy history, and DSA, all those things have, more to add to the story. So how can we optimize this? This is not good. And people, from different centers at different time frames have tried to validate multiple different prediction model to optimize the choice. So we apply one model, see what is the best donor in this big list that I have from NMDP, and choose the best one, hoping for better outcome. So we had, as you can see here, multiple different model that were introduced, and as you can see from this table, all those algorithms were not very predictive. They were excellent predicting outcome of 8 out of 8, but when it comes to 7 out of 8, those did not help. There's some algorithm that contribute to improve selection of donor were validated, and here we can see one of the validated and impactful model that was done by Pedala. This is looking at permissiveness of DP using TC epitope grouping, TCE, and in this CIB-MTR analysis of 8,000 patients, including children, reduced intensity, and BBSC, superior outcome was shown when permissive mismatch DP was compared with both fully matched DP and non-permissive DP mismatch. And this was true regardless of the disease type, disease risk, or conditioning intensity. So this is the first model that was valid in the 8 out of 8 and 7 out of 8. And we use this all the time in choosing our donor. Mostly, as you can see here, due to decrease in relapse when comparing fully matched to, a permissive DP, and then mostly due to decrease NRM when comparing to non-permissive DP. So non-permissive DP has higher non-relapse mortality, and permissive DP compared to fully matched have improvement in relapse. So that's the first mismatch that you could do in your transplant that could help with your relapse. The permissive mismatch was superior when was tested again, as I said, in 8 out of 8 and 10 out of 10, regardless of DQ status. So DQ status continued to show no role in this type of population, but was impacted. Was not impacted also when mismatch to A, B, C, D, R continue to show a benefit in choosing those DP permissive DP mismatch. Sorry. Another algorithm and model used the expression of DP, and based on alanine to guanine SNP at this location of RS 9277534, which marks HLA-DP surface expression. When we choose G guanine, the DP expression was high, and when you do alanine and that SNP, you get low expression of DP. And the idea here is that higher expressed HLA-DRP is in a transplant recipient that is not shared by the donor cells, is more visible to donor cells compared to low expression HLA-DP mismatch, and that leads to higher risk of GvHD. Very nice paper done by Britt. That was shown in donor with low expression mismatch, HLA-DP, and with the risk of acute graft versus host disease was higher for recipient with high expression mismatch, as was the risk of death due to causes other than disease. This was not true when the donor were of high expression DP. So mostly with the donor with low expression of DP. So since there is a significant interaction between conditioning, GvHD prophylaxis, and those important outcome in this HLA issue, we validated this algorithm in our population. And we chose a really very homogeneous reduced intensity, mostly actually milfinane-based regimens, and we use it in the tacrolimus sirolimus platform, as shown in this paper published in 2020. And with a very similar finding showing here excellent outcome of patient when we mismatch only single DP and have a low expression locus, mostly due to decreased NRM, just like shown in the other paper. Another model that we use a lot is similar to DP, but here basically based on the location of the mismatch along antigen presenting site. So the antigen presenting site on the position 91 is HLA-C. 0303, 0304 did not show any evidence of activity in vitro in this paper here. And then later was validated in large sample size of almost 8,000 patients, patients with leukemia, ALL, myelodysplasia, and a patient with C0303 and mismatched with 0304. We call it also permissive C, had better outcome compared to any other C mismatches or any other mismatches in general. And that showed improvement in GvHD, non-relapse mortality, and ultimately survival. So in this, as you can see in this Kaplan-Meier curve, we actually a C mismatch can even matches the outcome of 8 out of 8 patients. So a C mismatch will be treated similarly to 8 out of 8 patients. And in this paper also, they looked at the expression analysis for HLA-C using MFI test, and showed that very good correlation with the grade 3 and 4 GvHD and non-relapse mortality. And this patient had a good, in this study, they had a good 2,000 patient with the HLA-C mismatch pairs. So very large sample size with MFI and higher expression showing increase in GvHD, similar to that DP. Another algorithm, and probably that's the last one I'm going to discuss on this piece, is the B mismatch. And as you can see here, HLA, B, and C have this piece here of 5 signal peptide SP on the exon 1. And in HLA A and C, we have no variation in sequencing. So very homogeneous sequencing for A and C. But in B is different story. There's a B leader can have either methanoine or threonine, M or T, at the position of 21 right there. And when you have, a different combination, you'll have a more heterogeneous type of loci. So 91% of those will have 2 Ts and then become TT, and then some will have MT, but rarely to have MM. And this variation will influence, as you can see on the left side, the HLA-E expression, which is by itself influence the strength of NK cells and the T cell interaction. So HLA-E, as shown there, can have a higher NK activity and more T cell interaction, and this will lead hopefully mostly to GvHD and change in relapse based on NK cell interaction with the cells. In this study of 34,000 that I just mentioned earlier, again, 1,500 patients of those were single HLA-B mismatch, and they were able to validate with that large sample this model, median follow-up of 6 years. And just looking at the patient or donor leader genotype separately and compare with the absence of HLA-B-M. So M is always bad, TT is better, and we can see that, we could see here that presence of any M leader increased GvHD 3 and 4, and regardless of the combination of anything. So it's independent increase in GvHD, mostly the severe. And as it's shown in the right table here, with the combination, even with the patient and donor leader genotype also affected GvHD. So very interesting model, looking at this HLA B leader. Also B leader actually was shown to be important even with matched HLA-B and mismatched other loci. So if you have A or C or DR mismatch, your HLA-B leader is very important. As shown here, they have a nice model to choose HLA, and this paper is very nice to review. Basically, using this algorithm, we are able to choose which B mismatch is better tolerated with a specific patient HLA lead genotype. And if B is matched, which, mismatch A, C, D, R, D, Q is better tolerated also. Since more of the donor outcome is related to mainly increase in risk of severity of GvHD, can we improve now mismatch and related donor outcome with recent improvement in GvHD prophylaxis? So now you have the donors, and that's the best you could do. Can we improve it by the way that we do transplant? So, and for the last 10 years plus, we have shown, emerging of all of those therapies now that we are using to improve the outcome of those patients. And as you can see here, I put 3 options, but probably there's other things that I'm not going to discuss here. So to start, post-transplant cyclophosphamide has emerging role in novel strategy for GvHD prevention based on the immunobiological rationale that activated alloreactive effector T cells that is responsible for GvHD are selectively sensitive to the toxic effect of this drug, and that regulatory T cells can be spared and can cause improvement in GvHD in the later days. And based on the work done in Haplo before and then later in matched donor transplant, this was tested in mismatch and related donor. And this study was an NMDP sponsored multi-center study. And just to touch, it's an extensive study. I'm just gonna touch on a couple of things. In the study had 2 cohorts, one myeloablative, one reduced intensity, 40 patients in each, multiple different conditioning regimen. And as you can see here, 40 to 50% of patients on the study were of minority background. So it serves a big population of unmet need. All patients receive bone marrow graft. So this is only bone marrow graft design, and donors were preferred to be young. So they were going to more mismatches to prefer a younger age, as there is tons of recent data showing improvement of outcome of patient undergoing post-transplant cyclophosphamide with donor age. And then, as you can see here, 40 on the right side, 40% of patients receive more than 1 mismatch out of the 8. So the good population of patients who receive more than 7 out of 8. This table summarizes all the outcome of this 2 population, and it shows how successful this approach with overall survival of 72% and 78% in both myeloablative and reduced intensity. They saw more relapses in the MAC arm, possibly with a small sample size due to the selection bias. Maybe they had higher patient risk in there, and that is shown in the table. But NRM was successfully kept below 10% at 1 year, which is definitely better compared to prior historical that we just showed. Similar to all reports, also post-transplant cyclophosphamide produce a very good, decent, chronic graft-versus-host disease in the range of 30 plus minus percent, with severe is around 10%. Engraftment was good. with time to engraftment around 17 to 18, similar to what we see in a post-transplant setting. And but they've seen reduced intensity patient having graft failure in a 7.5%. So a decent number, similar to what was shown in the Haplo setting in Hopkins old study. So this is considered to be successful study and was thought to be promising. Also they looked at infection in here in this study, and they showed that it was similar to any post-sci platform. At the same time, and Dr. Hijazi had mentioned this study earlier, we were doing our own study, City of Hope, and we use mismatched unrelated donor with post-transplant cyclophosphamide. But the main difference here is that we use BBSC, as you see in this schema. We did not use bone marrow, so all our patients underwent BBSC. And then we had similar finding with the study, reflecting improvement to access patient of minority background. In our study, almost 60% of patients, probably reflecting the population in South California. We had, in this study, more than half Hispanic, African American, and Asian American. So disease-wise, this was mainly leukemia and MDS, and we had, I think, 3 patients of lymphoma in the reduced intensity arm. Nearly 50% of patients had comorbidity index of 3 or more, and third of them were high or very high DRI. So it's a really decent sick population. It's not, cherry-picked or anything. All the patients in our population had 7 out of 8, but we have 2 only patients, which is 5% only in this population that received 6 out of 8. This look similar to prior study from NMDP, and excellent outcome. As you can see here, time to transplant, this is not showing, but it was 16 days with no graft failure in our population. We used more in the reduced arm. We used melphalan-based, which is a little more intense than Flu/Cy that is used in NMDP study. So we have not seen any graft failure with our study. Median follow-up was close to 2 years, and it had 87% survival, excellent survival. And, Griff's was at 68%, similar to what we see in good Haplo paper. 1 year non-relapse mortality, again, the same, kept at 11%, so very close to that one. And, GvHD grade 2 and 3 was in the range of 50 and 18. Again, we see a little more higher grade acute GvHD because we used peripheral blood and melphalan-based therapy. So higher intensity, which showed us later that the relapse risk is lower, as we are all expecting, and higher GvHD, basically due to the higher intensity of regimen as well as the use of BBSC. So and that is important because 18% is a little bit on the higher side for this population. The rate of moderate to severe chronic graft versus host disease, even though the overall GvHD was 48, but really the severe form was only 3% in this population. I don't know if we got lucky with that, but usually it's around 10% with the severe when we use post-transplant cyclophosphamide. With a short follow-up, of 2 years, we did not see increase in relapse. It was only 16%. For really sick population. So that's really good. We did some immune reconstitution data also, and with possible non-significant delay in recovery, especially in reduced intensity conditioning of lymphocytes, including CD4 and 8. It got better with time up until day 118, catch up with the normal recovery. But this is all common in the post-transplant cyclophosphamide. And when we compare it with the Haplo patients that we've done with post-Cy, it was just very similar. We also looked at infection, as you see on the table on the right side, and we show that this is really what we see commonly in any platform, and there's nothing really different. We also, since we use peripheral blood, and the concern is CRS, we looked at CRS in this platform, and we found that 71% of patients had CRS, very high percentage with this peripheral blood platform. But mostly with this mismatch unrelated donor population was grade 1 and 2, and we did not see any grade 3 or 4 in this population. So fever, mild drop in blood pressure, but not really affecting outcome at all. CIBMTR had a site comparison and had a historical comparison with a cohort that they had. As you can see here, it was published in the same paper. And it's an interesting small population, though. They had 40 bone marrow and 60 peripheral blood in MAG and 40 bone marrow and 80 peripheral blood in the reduced intensity arm. So small number reflects a common practice in the States, and some people are doing peripheral blood, not only us here. So, but that was done earlier. So it probably was published in 2022. So then there was some people before 2022 that were using this type of platform and were just shown in the registry. But as expected, being on the study, I can refer you back to the manuscript also to review. Bone marrow patient and donor were a bit younger because they were mostly done on that NMDP study. Patients had better performance status, lower GRI and CD34, which in other paper we published correlate with CRS, and less comorbidities. So healthier population in the bone marrow overall. But in myeloablative setting, really we show here peripheral blood stem cell were superior than bone marrow in all aspects, including non-relapse mortality, relapse, and GvHD, leading to overall survival of 80% compared to 72% in bone marrow. So there is a good 8% difference that was significant in when you use bone marrow versus peripheral blood. That's in the myeloablative setting. And then when we looked at the reduced intensity, I think based on the population that was chosen on the study, I think that bone marrow patients perform a little better. Again, there is a higher percentage of BBSC patients were done off study and had a non-relapse mortality of 20%, which is based on the study that I showed is very high. And, that's probably why in the reduced intensity arm, bone marrow underperformed, bone marrow overperformed peripheral blood. So that's the post-transplant cyclophosphamide story. There is another platform that has been investigated around the same time, which is abatacept. So in this cartoon, as you can see, we show a basic APC presentation of antigen and activated and how we're activating T cells. And in this process, it starts with signal 1, which is MHC TCR based engagement. And again, after that, we have the signal 2, which is a CD80 engaged with the CD28 on the APC to provide co-stimulation. This will lead to T cell proliferation and activation and lead to GvHD in our setting, in the setting of transplant. Abatacept is CTLA-4 antibody that blocks the co-stimulation signal between CD80 and CD28, leading to inhibition of T cell proliferation and effector function, again against specific antigen that is presenting. And for ABA1 study, eligible patient received tacrolimus methotrexate, which is the old calcineurin inhibitor platform, and they added 4 doses of abatacept on day -1, +5, 14, and 28 after a myeloablative regimen. This study was done, show visibility, establish encouraging rates of GvHD, and then led to ABA2. But in this study, they did the pharmacokinetics, and they saw that those 4 doses of abatacept were covering the first 50 days of transplant, and that's why majority of the impact was on the acute graft versus host disease. Then an ABAT2 was published later. Primary objective in JCO, primary objective for this study was to determine the impact of abatacept on incidence in early severe acute graft versus host disease when added to standard GvHD prophylaxis, as mentioned before. In both 8 out of 8 and 7 out of 8. In 8 out of 8, they did a randomization, medicine versus placebo, while in 7 out of 8, they compare it to, it was single arm, and they compare it to cohort from CIBMTR. This very busy table compare the population baseline characteristics, and just to summarize, it's basically balanced population, but control arm had older donors since this is on study, they chose younger donor and had more bone marrow graft. And as we just showed earlier, the bone marrow graft were a little worse. So a little worse population with the cohort, with the control arm. Focusing only on the mismatch, since we are talking about mismatched donor, we're not going to discuss the rest of the paper, but focusing on mismatched population in the study, as we said in red, and using abatacept on this red line, and then blue representing the CIBMTR matched cohort, we can see significant improvement in the rate of 2 to 4 and severe GvHD, leading to excellent. They did a shorter type of endpoint called severe GvHD free survival that got the drug approved through FDA. This, though, did not translate to benefit in chronic graft versus host disease. And as we just discussed earlier, that 4 doses covering only 4 days, for 50 days of the transplant, and had no effect on chronic graft versus host disease. And now abatacept's 3 study will design to determine if we increase the number of doses and cover longer time, longer than 50 days, are we going to impact the chronic graft versus host disease or no? NRM was significantly better with ABA, but this is a significant increase after 12 months, possibly due to chronic graft versus host disease. We don't know exactly. That paper did not comment on that, with no change in relapse. This led to a better leukemia-free survival and overall survival. Again, this was compared to cohort who got methotrexate calcineurin inhibitor only. So we have to be careful that this is not considered a standard of care for mismatch unrelated donor, and they did not use ATG in that population. But later, when they compare it with a population of ATG methotrexate calcineurin inhibitor, which is considered the best we had for mismatch unrelated donor before, this overall survival benefit was not evident. So mostly affecting acute GvHD, the poor outcome on chronic graft versus host disease is a problem for this. They did later on exploratory analysis of overall survival and evaluated 7 out of 8 mismatch unrelated donor transplant recipient treated with abatacept, calcineurin inhibitor, and methotrexate, and they compare it, to post-transplant cyclophosphamide now. They just want to see what's the comparison between those two. Unfortunately, this comparison is not really complete yet, and but they focus on their endpoint, which is a short term, and as you see from Kaplan-Meier here, overall survival during 180 days of follow-up post this 7 out of 8, only 7 out of 8, no more mismatch unrelated donor transplant using the propensity score. There was no difference between both platform, abatacept or post-transplant side. Again, someone would expect, with all the things that we discussed about chronic graft versus host disease and the potent effect of post-transplant cyclophosphamide on chronic graft versus host disease, that those curves will separate really badly if you extend your comparison later. But we'll have to see what adding another 4 doses of abatacept to make it 8 total doses will do to the chronic graft versus host disease first. All right, so this is, also there's a lot of work done on graft manipulation that I don't have time to discuss, but most of the graft manipulation are still focusing on matched donor and haplo, and there's a small number of mismatch unrelated donor that are being used. Couple of possibility for mismatch, for graft manipulation that we are aware of in the clinical trials now is what is done in Stanford with the ORCA trial, and this is undergoing now, and we will see with the randomization what this will do against tacrolimus methotrexate. And in another trial, which is run in my center, where we use alpha beta and add back memory cells to the graft. Those are the most common graft manipulation that are ongoing now and will show results hopefully next year or so. But really, to look at the future direction, I thought this cartoon will be nice. Looking at the different type of area where we could interfere to improve further on GvHD, And, blockage could come on multiple different stages, as you can see here. Number one, we could target conditioning regimen and avoid GI injury to decrease antigen presentation. And we do that with a procedure called TMLI, total marrow lymphoid irradiation, where we are able to deliver radiation and avoid gut injury. And hopefully that will decrease GvHD. Those are ongoing studies and hopefully will produce some results soon. We could also interfere with the presentation on the other side, where we could block ABC or CD28 co-stimulation. As we know, proteasome inhibitor like Velcade was attempted with post-transplant cyclophosphamide combination and showed some promising results. Abatacept's results, as shown earlier with methotrexate, but then adding that to post-transplant cyclophosphamide, also published recently by the NYU group, and shows that it could be a promising combination. We could also, as you can see on this cartoon, inhibit the activation and proliferation of T cells, by blocking cytokine. Mostly the most common and popular drug is JAK inhibitor and other medication that are mostly specific to IL-12 and IL-23, those are in clinical trials. All of those drugs could be combined with post-transplant cyclophosphamide, causing some improvement. We have ongoing study that is half accrued now using itacitinib combination with post-transplant cyclophosphamide, and this hopefully will show some results early next year. Lastly, after T cells are activated and then are migrating to the GI to cause injury, maybe blocking that pathway by antibody against alpha-4 beta-7 integrin antibody, maybe like natalizumab or vedolizumab, are important also to decrease GI GvHD. And we have a clinical trial combining post-cy with vedolizumab that hopefully will start soon. And hopefully that will show some decrease in GvHD, GI GvHD mostly. So you can see multiple different platforms could be done for post-cy to improve the outcome of that platform. And hopefully we get rid of the MMF that hopefully will show improvement in acute graft versus host disease control, since we still see 30 to 40% of those patients suffering from that type of illness. I really try to hopefully stay online on time, and I would thank you all for listening, and we'll be happy to take questions.
Thank you, Dr. Malki. That was a wonderful presentation of how to try to make this better and get better outcomes through your HLA testing. Dr. Hegazi, want to take over the question and answer?
Of course. Thank you, Dr. Malki, for this excellent review. I wanted to ask you a question. So you did a wonderful review of the different alleles and antigens and mismatch. How does that translate in comparing the mismatches with mismatched MUDs and haplo? Because we don't look a whole lot on which allele is the difference when we're looking on the haplo, and the outcomes there is not very well differentiated. How does that how do you explain this? That there are those same mismatches that are in the 7 out of 8 are in the haplo, but we're not seeing the poor outcomes that most of the haplo.
No, this is very good question, Dr. Hegazi. This is important question from someone who deal with this on daily basis and wants to find how can we choose better. I think most of this data that I presented, and I kept focusing on this, that those patients underwent a conventional GvHD prophylaxis platform, and those are data that might not be applicable to what we see now when we use post-transplant cyclophosphamide. A mismatch, DR that was thought to be very bad initially is now being figured that could decrease relapse in patients who undergo post-transplant cyclophosphamide. So the game ball changed totally when you do post-transplant cyclophosphamide. There is There is some data on locus-specific outcome when you do post-transplant cyclophosphamide. Started initially from Northside in Atlanta, and now later they validated that in a NMDP big population of haplo. You have also a calculator that you could plug in that is on NMDP website, where you could plug in the mismatches you have in haplo, and you could get outcome, and you could compare different haplo by different score. I did not go through all of those because those are not validated in mismatch unrelated donor yet, and we don't have comparison studies to show what is DRB mismatch meaning in post-transplant cyclophosphamide between haplo and mismatch unrelated donor. But using a haplo population, mismatch on class 2 in general was decent, was good, was better tolerated, and actually DRB1 mismatch with post-transplant cyclophosphamide decrease relapse and improve outcome. Lead match B was similarly important in both post-cy and methotrexate tacrolimus. So if I would have to do anything for your question, if I have to do anything and extrapolating from data published in haploidentical transplant, I will mismatch DR if I can and try to choose a leader B match for that patient population for now, until we have further study on a mismatch population. The more patient we do, the larger number, and hopefully, because those mismatches, you need larger sample size to find their outcomes.
Good. We'll take questions from the audience.
Yeah, as mentioned, if you have a question, you can unmute and ask it, or if you want to post it in the chat area, we'll see it there and can pass it on to Dr. Malki.
For our internal medicine audience in this talk this morning, it's probably important to point out that haplotransplants are given from people who are related to the subject, whereas mismatched that we're talking about here are from completely unrelated persons who are matched only at their HLA loci. So there's a very broad question. Dr. Hegazi brought out the point that in haplos, we have not seen the bad, quote unquote, outcomes to the degree that we've seen them with the MUDs. But that may, I believe, and I'd like our person to comment here about this, have to do with a lot of genes completely outside the HLA locus that we're not talking about this morning that are mismatched in unrelated persons.
Correct. So no, thank you for your question. I agree. And I'm sorry if I did not clarify that those mismatch unrelated donor are totally unrelated patients. So those are incidental similarity on those locuses that we have described. And as you can imagine, you are seeing the tip of the mountain on those 8 locus, but you don't see anything else below in depth below that tip of mountains. And when you choose haploidentical transplant, you are taking a whole genome that is exactly the same that was inherited through the family members. That could be a reason why we see improvement. Also, another additional reason is that most of the patients who underwent haplo recent eras have been undergone transplant with the post-transplant cyclophosphamide rather than all the old type of GvHD prophylaxis. And the ones that I showed, half of what, in half of my lecture, first half was based on methotrexate tacrolimus, which is old GvHD prophylaxis that was not adequate for those mismatched donor. But later on, as I showed later, there was one paper showing that when you use the same post-transplant cyclophosphamide and you're comparing orange to orange, you are showing similar type of outcome between mismatch unrelated donor and haploidentical donor, which is the advances in this era where, mismatch unrelated donor used to have bad outcome. And as you said, haplo have improved also. I remember there was a couple of papers using methotrexate tacrolimus and ATG in haplo patients. That was in the, early, 80s, and it was published, and I could share with you those papers, and the outcome were as bad as mismatch unrelated donor, even worse. with those, and people stopped doing that long time ago until a group from England initiated this mice model and started to do post-transplant cyclophosphamide, and that was transferred later on to Johns Hopkins, where they did the early study with the Seattle, and then showed that in haplotransplant, when you use post-transplant cyclophosphamide, GvHD is better and outcome improved. I just want to make sure that we focus, based on all those outcomes. It seems like it's not the donor, mostly it's the platform that you use. It's the way that we do the transplant, and mismatching here or there could add a little bit, but the major improvement in outcome of this patient population happened after post-transplant cyclophosphamide was introduced as a GvHD prophylaxis.
Well, that was absolutely wonderful. Thanks for all the explanation of the developments that we've had and trying to, again, try to making the outcomes better.